Hello everyone, I'm Dr. Bharadwaj from Department of Conservative Dentistry and Endodontics, Sri Balaji Dental College and Hospital. I'm going to talk about calcific canals and its management. Introduction. Calcification, it is a process in which tissue becomes hardened as a result of precipitates or larger deposits of insoluble salts of calcium, especially calcium carbonate and phosphate. Calcification is of two types, metastatic type and dystrophic type. Calcifications are common in the dental pulp with a tendency to increase with age and irritation. In dystrophic calcification, deposition of calcium salts in dead or degenerating tissues occurs with the normal calcium metabolism and normal serum calcium level. Metastatic calcification, it occurs in apparently normal as well as in injured tissue when the physiologic mechanisms controlling the calcium balance are disturbed and particularly when hypercalcemia is present. Calcification of tissue components. The initial calcification of a component of pulp tissue, collagen fibril, ground substance, and necrotic cell remnants serve as focus upon which calcified material is subsequently deposited in a concentric, lamellar, or in radial fashion. These are termed as pulp stones and is most commonly seen in coronal pulp. Pathogenesis of pulp calcification. Initially, a compromised circulation occurs, resulting in fat droplet deposition, vacuolization of odontoblasts, reticular atrophy, fibrosis of pulp, hyaline degeneration, leading to fat replacement and mucoid degeneration, causing calcification. Local conditions such as pH level, the activity of carbonic anhydrase, and phosphate concentration probably act to accelerate the rate of deposition. Mineral composition. Aoba et al. In 1980, in a chemical analysis of pulp stones, reported inorganic content of pulp calcification about 63% of its dry weight. Another study reported that denticles were composed of two major elements, calcium and phosphate, with a mean concentration of 32.12% and 14.69%. Cisco's in 1990 found that pulp calcification contained large amounts of citrates, proteins, and phospholipids. Chemical composition in inorganic, it contains uh, calcium phosphate, calcium carbonate, calcium oxalates, occasionally complexes with magnesium and iron. Organic composition contains citrates, proteins, phospholipids. Calcification of pulp can occur due to aging and mineralization in response to various irritants. Pulp changes with age. Teeth age not only with the passage of time but also under the stimulus of function and irritation. Age is a chronological occurrence, but even more importantly, an aged tooth may represent a premature response to the abuses of caries, extensive restorative procedures, and inflicted trauma. Since the pulp reacts to its environment and is in intimate contact with the dentin, it responds to abuses by altering the anatomy of its internal structures and surrounding hard tissue. Genetics. Cisco's reported to support genetic factors to be involved in occurrence of pulp stones. 10K is of opinion that the formation of pulp stone is congenital, as in some patients all teeth are filled with pulp stones. Caries. When the pulp is subjected to rapid and overwhelming bacterial invasion, little time may be available for normal reparative dental formation. Dental pulp may die rapidly, leaving the canal space patent but full of necrotic and often infected tissue. If the irritants impact the tooth slowly over a long period of time, both the pulp chamber and the pulp canal system undergo calcific changes that may impede access during root canal procedures. Traumatic injuries. Common problem in children and adolescents, and the prevalence of such injuries has increased over the last 10 to 20 years. Pulp canal obliteration is a typical sequela to many forms of trauma, in particular to luxation injuries. In the literature, pulp canal obliteration has been found clinically to range between 6 and 35%, averaging about 1 in 5 luxated teeth. In majority of the cases, pulp canal obliteration does not lead to pulpal necrosis. So, does the tooth need a root canal? RCT is advised in these cases because of reduced cellular content leading to decreased ability for healing, therefore making the pulpal tissue more susceptible to infection. In 1965, Patterson and Mitchell felt that a tooth that had signs of calcific metamorphosis due to trauma should be regarded as a potential focus for infection and root canal therapy should be initiated. Jacobson and Kerekes recommended delaying the treatment until symptoms or radiographic changes develop. Iatrogenic. Pulp calcification in reaction to orthodontic forces. Kaklatova in 1992, in a light microscopic study of pulp morphology following orthodontic treatment, reported that pulp stones and diffuse calcification were often encountered in orthodontically treated teeth. Deep bases such as calcium hydroxide and ZOE, rather than protecting the pulp, are irritants designed to stimulate secondary reparative dentin formation. They sometimes cause atrophy, pulposis, and premature aging of pulp. A high incidence of mineralized canals has been observed following pulpotomy and direct pulp capping by Seltzer and Bender 1984. Pulp stones. The pulpal calcifications are identified as focal intrapulpal radioopacity in pulp chamber or as diffuse radioopacity in the root canal, giving an appearance of calcific obliteration. Routinely, dental periapical radiographs or bite wing radiographs are used to demonstrate pulp stones. Pulp stones may be important to clinicians who attempt to access preparation or to negotiate canals. It may attain large size and occupy considerable volume of coronal pulp. It can alter the internal anatomy and confuse the operator. Attached denticles may deflect or engage the tip by exploring instruments in the canals, thus preventing their easy passage down the canal. The large discrete masses occasionally appearing to nearly fill the chamber are likely to be of natural occurrence. The chamber that appears to have diffuse and obscure outline may represent a pulp that has been subjected to persistent irritant and has responded by forming large numbers of irregular pulp stones. This finding is a diagnostic aid and indicates a pulp is exposed to uh, chron- persistent chronic irritant. Hence, anatomy of the pulp chamber floor is very important. Uh, Paul Kreisner and Henry J. Rankoff in 2004 uh, did a study using 500 extracted teeth, which were maxillary and mandibular anteriors, premolars, and molars. Two categories of anatomic patterns were observed. Relationship of pulp chamber to clinical crown. The following observations were noted. Law of centrality. The floor of the pulp chamber is always located at the center of the tooth at the level of CEJ. Law of concentricity. The walls of the pulp chamber are always concentric to the external surface of the tooth at the level of CEJ. Law of CEJ. The CEJ is the most consistent, repeatable landmark for locating the position of pulp chamber. Relationship on the pulp chamber floor. Law of symmetry 1. Except for maxillary molars, the orifices of the canals are equidistant from a line drawn in a mesial distal direction through the pulp chamber floor. Law of symmetry 2. Except for maxillary molars, the orifices of the canals lie on a perpendicular to a line drawn in a mesial distal direction across the center of the floor of the pulp chamber. Law of color change. The color of the pulp chamber floor is always darker than the walls. Law of orifice locations. First location is it is always located at the junction of the walls and the floor. Law of orifice location 2. The orifices are located at the angles in the floor wall junction. Law of orifice location 3. Orifices are located at the terminus of the root developmental fusion lines. Hence, to locate the calcified orifice, a clinician should first mentally visualize and project the normal spatial relationship of the pulp space onto a radiograph of the calcified tooth. Then the two-dimensional radiographic image is correlated with the three-dimensional morphology of the tooth. Thereafter, access cavity preparation is done. These pictures are show access cavity preparation in maxillary central incisor. The angle of the access preparation is approximately 45 degrees to the long axis of the tooth. The access opening should not extend incisogingivally to include the full middle third of the crown. No pulp chamber is found in the calcified canal, so continued burr penetration may result in facial perforation. So mesofacial perforation results from excessive burr penetration without adequate radiographic control for burr angulation and pulp canal depth. So angle of the burr is changed from 45 degrees to an angle as close to parallel as possible with the long axis of the tooth. Penetration proceeds down the lingual aspect of the with frequent exploration with DG16 Explorer. Another technique is lateral radiographic technique, which is used to identify the position of the burr. The first picture shows radiograph of the calcified tooth. The second picture shows the radiograph of the tooth with an L and burr centered mesiodistally in the tooth. The third picture shows the placement of IOPA horizontally in the buccal vestibule to obtain a lateral view of the uh, central incisor. The fourth picture shows the lateral radiograph, which where the LN burr is deviating labially. So this can be used to correct the position of the burr, and access cavity preparation can be done. Clinical tips for recognizing orifice location. It can be accomplished using DG16 Explorer, can be confirmed using radiograph images. Then magnification in the form of telescopic loops or an operating microscope is extremely useful. Dentinal mapping, ultrasonic instrument usage, then fiber optic transillumination device, which can be used on the external surface of the tooth to eliminate mineralized areas of the chamber and the root. The light does not pass through mineralized areas because of lack of open continuous dental tubules, which can be used uh, to identify the pulp canal space. Extended burrs such as LN burr or M burr are useful for access preparation. Canal blue dyes can be used by coating it on the pulp chamber floor and leaving it for 10 seconds, and it is rinsed and dried. The canal orifices will be identified as simple blue spots. The composition uh, includes colorant in propylene glycol, water solution, and emulsifiers. Management of problems encountered in locating the orifice. The majority of attempts to locate canal orifices will be successful, however, the potential for perforation always exists. The most common sign of accidental perforation is bleeding, but bleeding may also occur if the pulp is in the calcified canal is vital, and accidental perforation with non-bleeding is also not unusual. In case of perforation occurs, a small instrument can be placed and a radiograph must be taken. A frequent result of vigorous probing with the fine instruments and chelating agents creates false canal. Confirming the position of the instrument with a radiograph is always necessary. Sealing the site is sometimes impractical if the orifice of the canal is yet to be located. If the perforation site is left exposed, then only water or saline should be used as an irrigant during subsequent procedures. If the tooth is closed at that appointment, then calcium hydroxide is placed is the best medication for interim intracanal medication. Once the canal has been found and treated, perforation should be sealed permanently with MTA, over which a GIC is placed. If periradicular pathosis or symptoms develop, then surgical intervention will be necessary. Guided endodontic access cavity, a new method was introduced for the treatment of calcified and periapical pathosis. With the help of special software, alignment with the CBCT and surface scan allows virtual planning of an ideal endodontic access cavity. Subsequently, a template can be produced by means of a 3D printer. This template guides a minimally invasive drill to the calcified root canal. This image shows the CBCT planning over the calcified canal tooth. Figure A shows preoperative tooth. B shows the template adapted to the teeth, and C shows initial preparation, removal of enamel and exposing the dentin. 4 shows the template with the incorporated sleeve, and E shows the guided preparation through the sleeve, and F shows the access cavity preparation. Preparation and negotiation, technique rationale, and method number 1, full canal preparation. 21 number 8K file is the initial instrument of choice to negotiate calcified canal. The use of nickel titanium files is contraindicated for this purpose because of lack of torsion strength. A rubber stop is placed on the shaft of the instrument which has one directional point. Before file insertion, a small curve is placed in its apical 1 mm. The point on the rubber stop is then aligned with the curve. The pre-curved instrument must be directed along the pathway of the canal is most likely to follow. Consequently, knowing the direction in which the curve in the instrument is pointed is very important. Observing the rubber stop on the instrument shaft makes this determination easy to accomplish. Technique national and method number 2, coronal to mid-root penetration. Visual location of identified orifices and canals is essential. Negotiation with small file 2 to 3 mm into the orifice is important. This will determine the initial extent of the canal patency. If the file can penetrate further, doing so must be done with care, but obtaining full canal length on the first pass should not be attempted. The file should be used in circumferential manner, opening the orifice. The file should be removed and the orifice should be irrigated, and the canal and the file can be placed in the to the same depth. It should fit loosely. If not, the first step should be repeated with the number 10 or 15K file. As the irrigant penetrates into the small opening, the files will loosen the debris and begin to create a coronal pathway to the middle portion of the canal. At this point, a number 10 or 8K file may be used to penetrate deeper into the middle third. If successful, the orifice should be irrigated and the file should be used to loosen the debris. Excessive apical pressure should be avoided, and the last two steps may have to be repeated multiple times to gain the access. Copious irrigation with sodium hypochlorite and EDTA along with the use of chelating paste are recommended. Once the middle portion of the canal is opened, the apical can be approached in a similar manner as described. The philosophy of this approach is based on two concepts: the use of crown down canal technique and the limitation of application to only small segments of the canal instead of trying to gain full penetration immediately. This technique should be used to open all orifices and canals before determining working length. Technique national and method number 3, mid-root to apical third penetration. A stainless steel file, with a slight apical curve should be used to penetrate beyond the middle third of the canal. A probing and very gentle start winding movement should be used as an instrument in is advanced another 1 to 2 mm into the canal. The middle portion and the junction of middle to apical portion of the canal can have highly variable anatomic challenges such as rapid narrowing, canal deviations, and canal junctions. The newly penetrated space is filed until the instrument freely slides into the apical level achieved in step 2. Forcing a number 8K file too vigorously may lead to ledge formation or blockage. Once the estimated working length of the tooth has been reached, the number 8K file should be used in a filing motion until a number 10K file can be passed freely to within 1 mm of the length. Once this length has been achieved, the file should be kept at that point in the canal and a radiograph should be obtained to verify the working length of the tooth. So the purpose of chelating agents are: the chelates are stable complexes of metal ions with organic substances as a result of ring-shaped bonds. The stability is a result of bond between the chelator, which has more than one pair of free electrons, and central metal ion. Chelates bind and inactivate metal ions, in particular during their demineralizing effect on dentinal hard tissues when used in the form of EDTA. Detergents have been added to the solutions of EDTA to reduce surface tension uh, of the chelate, thereby facilitating the wetting of the root canal wall and increasing the ability to penetrate the dentin. Role of chelating agents are: it assists in penetrating calcified or black block canals, removes the smear layer that is created during the canal shaping, lubricates the canal during the use of hand and rotary instruments. How to use chelating agents most effectively? In combination with sodium hypochlorite to enhance both cleaning and antimicrobial properties, introduced with a file or injection paste or passively delivered as a liquid, with ultrasonic applications to possibly enhance its properties. So hence the final points to remember in negotiating canals with calcification are: copious irrigation should be used at all times. 2.5% to 5.25% sodium hypochlorite enhances the dissolution of organic debris, lubricates the canal, and keeps dentinal chips and pieces of calcified material in solution. Slowly advancing the instruments in fine or calcified canals is recommended. The instrument should be cleaned on withdrawal and inspected before reinserting into the canal. When a fine instrument has reached the approximate canal length, it should not be removed, rather, a radiograph should be taken. Acids or alkalis should be used to aid in canal preparation. Chelating paste or solutions should be used to assist in canal penetration. Ultrasonic instruments should be used in pulp chamber to loosen the debris in canal orifices. The canal orifice should be flat and any negotiated canal space should enlarge to improve tactile perception in continued canal penetration. Newer nickel titanium rotary orifice penetrating instruments should be used with gentle pressure until resistance is met. Conclusion: formation of calcification deposits within the root canal of a tooth have historically been difficult clinical endodontic complications. Presently, removal of such tissue mineralized through the deposition of calcareous materials in the root canal remains resistant to conventional endodontic techniques. The subsequent treatment primarily involves undesirable surgical procedures and loss of tooth. Clinician must understand that pulpal calcifications are signs of pathosis and not cause of such as such. The nature of calcification is often unpredictable and can create significant clinical challenges. Thank you.